So my name is Juveria Zaheer. I am a psychiatrist here at CAMH. I started my residency training here in 2007, and I remember when I first walked into the CAMH Emergency Department. I'd never been there before. I had trained at Queen's University, and I couldn't believe that there was a place where people could just walk in the door and get emergency mental health care. We'll talk about how the models of care are a little bit different in other places. I was really struck by the team environment and the commitment to treating people who walk through the door with dignity and care and to connect them with services that they deserve and that they need. Although I know that our system is really fractured and it can be very difficult getting the right services for people, and I completely understand that frustration. Um, I often say that people who are coming to see us in the CAMH Emerge are coming to us on the very worst days of their lives. And we also know that things like depression, anxiety, substance use can make us feel like we don't belong or that we're bad people or that we deserve to be punished or we're not deserving of help. So the first thing we often say is, we're so glad that you're here and how can we help? Um, One of the things that is struck me over the years is how our numbers have grown. So I graduated from my residency in 2012 and did a research fellowship at that time. At that time, we were seeing about, when I started my residency, we were seeing about 350 cases per month. By the end of my residency, we were seeing about 700 cases per month, and now we're seeing over 1,500 cases per month. So well over 15,000 people per year. We are the busiest psychiatric emergency department in the city. We do about 40 to 60% of all psychiatric care in downtown Toronto. We have the highest rate of police drop-offs in the city. And it is just a real pleasure to work in this setting, although it can be busy and chaotic and definitely stressful for the patients. We really pride ourselves on having a large interdisciplinary diverse team. So Mark Green, who is our manager, he really wants to have a team in the Emerge that really represents what Toronto looks like, and that's hiring folks across the ethnic diaspora, the Black diaspora, making sure that people can feel comfortable and safe in our setting. And when I was hired to work in the CAMH Emergency Department, I was physician number 6. And now we have about 53 physicians who work regularly in the CAMH Emergency Department, all of whom have an interest in emergency psychiatry and acute care. When I was a resident, we had 2 docs working from 8:30 to 5 every day, and then residents would cover off the rest of the time. Now we have a full component of staff physicians who work 24/7. So no matter what time of day you come, there will be a staff psychiatrist who's working in the hospital. So in terms of my own journey, I started in 2012. I oversaw resident education for many years, and then in 2021, I became the medical head of our service. Next slide. Oh, sorry, I should do my next slide because I have control of the slides. I'm so sorry. I just want to start by saying that emergency departments are hard places. They are busy, they are loud, they are overwhelming. I know that it feels like a black box. So when you come in and you register, you think, oh my gosh, there may be like nobody in this waiting room. Why is it taking me hours to be seen? Not knowing that maybe there are 3 or 4 other waiting rooms that are really, really busy with folks who are being seen. And there's also something called triage. So if people come in with police or experiencing active psychosis or distress or suicidality, those folks are often seen first. And if you're coming for another super, super important reason, but if you want a second opinion or a med refill or diagnostic clarification, those folks often have to wait a little bit longer. It can be loud, it can be overwhelming, there can be police around, there can be security around. So we do whatever we can to make it feel dignified and safe, but it is a very stressful place to be. And you add on top of that you're coming on a day where you're feeling a lot of stress. It can be really challenging. And I think that when we think about stressors, we need to think more broadly. So of course we are a hospital and we manage acute psychiatric emergencies, right? Like opioid use disorder, alcohol use disorder, anxiety, depression, trauma, bipolar disorder, intoxication, schizophrenia. But I think we also have to remember that our patients and their families are people too, and that life can be really hard and stressors come in all kinds of different shapes that aren't just worsening mental health concerns. Death or illness of a loved one, abuse or neglect, losing access to your external service providers, especially people who are, 17, 18, who are graduating or have moved away from home for university, financial stress, homelessness, experiences of oppression and trauma, loneliness and isolation, and the ongoing pressure people feel across all psychiatric diagnoses to kind of keep it together, to keep it together at work, to keep it together at home with your family. It's exhausting. And so one of the things that's important is that we need to remember that our patients are bringing all kinds of experiences to the table. And for things like suicidality, just focusing on their mental health concerns doesn't really do them a service because we need to understand them as whole people. And I think the other thing that's really important is that family members often come to these environments, and especially with COVID, it was super stressful because we're trying to minimize the number of folks in the department. But I think it's our ethos that family is really, really important, and family can take many shapes, right? It can be a biological family member or someone you're in a relationship with. It can also be for some people, their chosen family, their friends, their other supports. And it's really important for us that we talk to those people. And so you always have a right. Sometimes people may say in an emergency department, if you're a family member, well, we can't talk to you because your loved one doesn't want us to talk to you. But it's your right as a family member to always give information. So it's your right as a patient that we can't release information unless there's a really significant safety issue. But if you're a family member, you can always give information. And I think that's a really, really important right for both patients and families. Next slide. Oh, sorry. Oh my goodness. So what are our values? I think that's always a good place to start. So I want to start by saying that in a perfect world, we would not need emergency psychiatric care. In a perfect world, everybody would get the care they need when they need it. Care would be in the community, care would be with family, care would be person-centered, and the sad truth is that, although we've made massive strides as a society to understand mental health and to understand that people with mental illness are deserving of hope and help and care, there is a lag between what the awareness is and what the ability to meet people's needs are. And I think there's a big difference between what you can get in Toronto and what you can get in Timmins, or what you can get if you have one diagnosis versus another diagnosis. And so, we really have to appreciate, I think, as emergency psychiatric team, that we can be really oppressive, right? Like we can hold people against their will. We can end up placing people in restraints, which is extraordinarily traumatizing. And so in this society where we exist and we serve a purpose, how do we kind of live our values? The other piece is that sometimes it's very difficult to access any kind of care. So we often get people who are sent in by their family physicians who just can't get a referral made. And, it's really tricky because we want to help support everyone we can, but it's also a matter of meeting everybody's needs and managing a limited resource. So in terms of what we try to stress in our department is we want to provide safe, dignified, evidence-based care to people experiencing mental illness and addiction. We want to support our healthcare system by being a hub for emergency mental health care in the city. We want to provide comfort to people who are suffering and afraid, and we want to represent our values, which include diversity, equity, and meaningful inclusion. So how does the CAMH ED work? So first I want to start by talking about what you normally see in a general hospital. So CAMH is the only dedicated psychiatric emergency department in Ontario. In a general hospital, what happens is that you come into the general hospital like any hospital in Toronto, and they also provide excellent psychiatric care. So you would see an emergency physician, and that emergency physician would talk to you about your concerns. If they feel that it's something that you don't need to see a psychiatrist for, you can get a referral for maybe outpatient psychiatric care in the same hospital, get started on treatment, have your withdrawal managed, for example, or they can refer you to their psychiatric service. And that psychiatry service, often comprised of psychiatrist residents and crisis workers, will come see you. They'll do an assessment and they will determine what happens next. Like, do you get admitted? Do you get outpatient follow-up? What comes next? Our model is a little bit different because we don't have emergency physicians who work there. We have a medical doctor who does help 8:30 to 4 every day. But if you come in, you're going to see a psychiatrist or psychiatry resident supervised by a psychiatrist. And we also provide, really good, strong interdisciplinary care. We have different resources that are available to us in CAMH and then different inpatient units as well. Sometimes people ask me, well, should I go to a general psychiatric hospital or to CAMH? And so I think that can be a tricky question. One thing that I will say is that if it is a psychiatric emergency, like you don't know if you are safe in the moment or your loved one is safe in the moment, it's always best to go to your closest emergency hospital. Like sometimes I'll meet like really wonderful families who are trying to drive in from hours away, but the person is really, really unwell in the car, and that's not an ideal situation. I think also too, it's important to go where your care is, because continuity of care is one of the most important things. So if you have a psychiatrist at another hospital, if you come to CAMH, sometimes it can be tricky for us to connect with your psychiatrist. Sometimes that team might want to transfer you back to that hospital. Like it just becomes a little bit chaotic. There's duplication of services. So I think if you have a team somewhere, it's often best to follow up in that hospital. And then the other piece too is around general medical concerns. So, all of us are trained physicians for sure, but there's things that we don't have at CAMH that can be really important. So, for example, I can't get blood work after 1 p.m. I can't get ECGs or X-rays after 1 p.m. We can't, although we can do things like IVs, fluid rehydration now, we couldn't do that before. If you need to be on a monitored bed, if you're experiencing delirium, like these kind of really acute medical concerns, if you've if you or a loved one have overdosed on medication, but proximally, we really, 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 really encourage you to go to a general hospital because we just don't have the capacity. And what ends up happening is if you come to us and you're really medically unwell, it's really not super patient centered because we have to send you out to either via 911 to a local hospital or to our partner hospital, Mount Sinai. Then you have to restart the process all over again. Then you have to get seen and then you have to get transferred back. So if there are medical concerns, I think a general hospital does make a lot of sense. And so in terms of our model of care, so what happens when you walk in the door at CAMH is that, so there's a couple ways of doing it. So we can start with like if you're brought in by police or if your loved one or you are brought in on a Form 1, we have a special entry for police triage just to minimize the exposure for patients with trauma around police and also to get the police back doing their jobs on the road. And then you're seen by our team. We take care and then we'll make a decision about disposition at that time. If you come in, say it's 9:30 on a Thursday morning and you are feeling really overwhelmed and at your wit's end, and you come into the CAMH Emerge, what would happen is that you would see a triage nurse. That triage nurse would talk to you, in a kind of a brief assessment about why you're here, how can we help, what kind of supports do you need. If you probably don't need admission to hospital, but you definitely need ongoing support and care and an assessment, if there's space, we will often divert you to our bridging clinic, which is great because you'll see a psychiatrist. The wait times are going to be shorter and it's like less stressful than sitting in an emergency department. It feels more like outpatient care. If bridging is full or the condition is a little bit more serious, like there might be like active safety concerns or active psychosis, then you would stay in our emerge and be triaged and be seen by one of our doctors. We also have social workers and pharmacists. Our pharmacists are excellent just to help clarify everything. In terms of what can be really helpful, if you're coming to a psychiatric hospital, always good, or any hospital, to bring a list of your medications because it can be really tricky when you're feeling stressed to remember what medications that you're taking. And then I think it's really helpful for us to know what is different right now. So how can we help you right now? What's different than how you're normally feeling? And I think it's really good as patients, in terms of patients, to be transparent about what you want. My point of view is that if somebody is wanting an admission to hospital, there should be a really compelling reason why we don't admit them to hospital. And sometimes people want to come into hospital, but the resources that we offer don't really map up with what they're hoping for. So sometimes folks will come in looking, for example, for a 28-day rehabilitation program. But unfortunately, as much as I wish I had a magic wand, as much as I wish I could do that, I don't have access to that. Or people may want support with cocaine use disorder as an inpatient, but that's not care we provide at CAMH. Some people may want longer, kind of more therapeutic admissions for 2 or 3 months. That's something that we don't really do at CAMH, but there's all kinds of reasons that we can, like all kinds of support that we can offer and reasons that people should come into hospital. And the other piece to that, if someone really doesn't want to come into the hospital, we better have a very, 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 very compelling reason to force them to stay, because staying in hospital if you don't want to stay is extraordinarily traumatic and really, really stressful. And in and of itself is not really an evidence-based intervention unless there's something that you're treating. So if someone is coming in with psychosis, we can treat that psychosis and the person will get better. If someone has a very severe, severe, severe mood disorder, doesn't want to be in hospital, feeling very intense suicidality, but they have psychosis, so they're not really connecting with the things that normally bring them value or meaning, or they just feel like too distressed to make a decision. That's another really good reason to come into the hospital. And it's our responsibility also to find you and connect you with good outpatient care. And just in terms of alternatives, so you come in, you get seen by a psychiatrist, we talk, we kind of try to build a plan together collaboratively. If you're having concerns around things like access to housing or access to outpatient care, our social work team will see you and provide support with that. get you referrals, either like sending you back to your local, and that's why it's also tricky to come from far away because we just don't have the same resources available to you if you come from far away, but getting you connected with resources as much as we can, in consideration of inpatient hospitalization. If you're admitted to an inpatient unit, often just like any hospital, and we're really, really working on it, it's a real priority for us to make people move through the hospitals with really good flow, because the last thing we want is someone sitting on a stretcher in a waiting room. It's undignified, it's stressful, it's triggering, it's not a good experience. So we would admit you to a bed as soon as a bed is available somewhere in the hospital. Alternatives to EDs, things like 988 is a really wonderful resource that I know was put in the chat. I think like rapid like drop-offs, connecting with your team, connected with family physicians. I think anytime we can avoid coming to an ED, it can be really helpful because the ED experience is imperfect for sure. And so thinking about what alternatives you have, where is the ED on your safety plan can be really useful. And what if I have a disappointing experience? So it's our responsibility again to take feedback. When I started as a resident, and in my early years as staff, we didn't do any opioid use disorder treatment. If you came in with opioid use disorder, we would say you can't come in, because if you come in, you're actually going to be at higher risk for death because you're going to lose tolerance. And that was really disappointing and stressful. And our team didn't like it, and our patients obviously didn't like it. But now what we can do is we do have the opportunity to help people who want to start Suboxone in our emergency department, and then to connect them with resources afterwards. So, when you have disappointing experiences, it's always worthwhile sharing them. We sort of take a model of like wanting to um, think about truth and reconciliation and support, and like trying to figure out how we can help and meet your needs when we can. And also sort of thinking about also making sure that our staff feels safe. I think people with mental illness much more often are the victims of violence and trauma and oppression than the perpetrators. I want to make that very, very, very clear. But in any hospital, we do ask our patients, even on these very hardest days, if they can, to treat our team with respect and dignity, and to make sure that we don't compromise our team's safety as well. So what do we ask about in the ED? So what can you expect? I think sometimes it can be really stressful because people have no idea what to expect. And I know that sometimes people come in and they're hoping for, a full, very thorough, hour-long psychiatric assessment with recommendations and a plan and follow-up. And sometimes that can happen, but remembering that it is an emergency department. So in an emergency department, we sort of deal with the acute picture in front of us. So it may not be the place to go if you've been suffering for, months or years and you kind of want to get things sorted out. Outpatient care tends to be a better option for that. But what we try to do is establish a baseline. So baseline means two things, right? One, it can mean, what do I look like when I am at my most well? When I'm at my most well, if you met me, what would my life be like? So thinking about that question before you come in is really, really helpful. And then I think the other baseline is, so it's like, what am I looking like when I don't have any illness at all? But the second question is like, what do I look like when I'm depressed but not as sick as I am right now? So a person may say to me, when I'm well, I'm working, I'm enjoying life, I love to work out, I connect with my family and friends, I don't have any suicidal thinking, and I don't have panic attacks. I know when I'm in a depressive episode, I tend to feel more panicky. I tend to withdraw. I can still usually make it to work. I usually drink a little bit more alcohol. I have fleeting suicidal thoughts, but not that many. But right now, today, 3 months after my depressive symptoms started, I'm thinking more about suicide. I can't go to work. I've missed work for 3 days. I'm drinking more, and I'm fighting with my parents, and I don't see a way forward, and I feel hopeless. So thinking about where you are compared to where you normally are when you're at your very best, and then where you are when you're kind of struggling, but it's not an emergency. What makes this an emergency is really helpful. We always want to assess safety, so we ask a lot of questions, and we hope in a humane and dignified and supportive way around suicidality, and not just about, remembering that asking about suicidality isn't just about like, are you going to do this or not? I think that's a really bad approach. I think it's remembering that having suicidal thoughts is very painful and stressful for people, and in and of itself is a reason to get hope and help. And so focusing less on predicting whether someone's going to die and more about understanding what their pain and suffering is, what it means to them, what are the things that make it better and worse, and how can we intervene to help support, and what are the things that help protect them, and how can we strengthen those. We want to make sure that we adapt our approach. So there are some folks who come in who are experiencing florid psychosis, who are terrified of being there, who are agitated, who are distressed. the best thing I can do to support that person is to give them medication and to make sure that we avoid things like physical restraints and chemical restraints whenever possible. And the CAMH Emerge, our restraint rate for people coming in to see us is about 3%. Across the country in psychiatric emergency departments for psychiatric patients, it's about 24 to 27%. So we work really, really, really hard to be as least intrusive as possible. Understanding the family environment and allowing support people to be there. I think that's really important. So we've moved beyond sort of like just thinking about the family as a person as an individual person and understanding the people who are important to them. Figuring out a helpful disposition, like as between the patient and the family. And I think being very transparent and honest is really important. So, sometimes a family will come in and they'll say, well, why aren't you admitting my loved one? They really, really need help. It's my responsibility then to sit and explain what my rationale is and why I think the program, the plan I'm offering is going to be more helpful, or what the dangers of admission may be. And then connecting with partnerships and supports. Another thing that can be really helpful when you come in is to have a list of your resources and their phone numbers, because we always like to follow up with your therapist, your psychiatrist, and that way, if we have it on hand, it can be really helpful. The other thing is to make sure, if you can, and I understand that this is a real equity issue because some people don't have access to phones or email, right? But if you can make sure that the admitting clerk has your like the best way to contact you. If we make a referral, the worst thing in the world is if we make a referral and we call the wrong number, and then you don't get care. That's really, really heartbreaking, especially for students who may be coming from, Saskatchewan, and they may have their Saskatchewan number, but we may have the wrong one on file. So please, please, please make sure, and it's our responsibility to double check with you, make sure what information we have, and how we can best understand it. And then things like being aware of strategies to keep everybody safe and comfortable. So all of our rooms at CAMH now are single rooms. In the old days, they were shared rooms. And you can imagine being in a mental health crisis and sharing a room with someone is really stressful. Making sure people have privacy. Our team, we have nurses. We also have program assistants who will kind of come and sit outside in the milieu, so you're not feeling like you're behind a closed door. They check on everybody every 15 minutes. We have lots and lots of food. So if you're ever hungry when you're with us, please ask for food, because we have, granola bars and juice and snacks and stuff, because it's really tough. Respecting your space. So if you're safe to kind of go for a walk and come back, we can give you a call, that kind of thing. Making sure that we modify our communication. Like, it's not appropriate for me to communicate with a 16-year-old in the same way I would communicate with an 88-year-old, or to communicate with someone who's having an active panic attack, with someone who is experiencing psychosis. So I think we have to make sure that we can adapt our style to make everybody feel safe and comfortable during the assessment. And part of that is respect for people's privacy, autonomy, and dignity. So if a patient, what we often do is we ask the patient to see them alone, and then we will see them with family. And then if the family prefers, we can also see the family member separately, because sometimes it can be tricky to give information in front of your loved one because you want to preserve your relationship with them. So in terms of initiatives in our ED, some things that are really important to us. So the first is gender affirming care. So I have one of our staff docs who just finished his PhD, that I was so lucky to supervise, is Dr. June Lam, and he did some really excellent work around the experiences of trans and non-binary people and coming to urgent psychiatric care. So he looked at the data to see, what happens to these folks when they do register in emergency departments, and then he did some qualitative interviews. And then we've also done a lot of interviewing with our team and staff to say, how can we best support gender affirming care? So we've changed a lot of our paperwork to make sure that people don't get misgendered, changing our forms, asking about pronouns, making sure people's name is correct, not using dead names. Also having, things available to folks that can help preserve and maintain their gender expression is really important. And then improving our handover to make sure that these things don't get missed is really important. Addressing structural and systemic racism. So we're doing a lot of work, interdisciplinary work, around like restraint rates across different races. What we found is that the differences in restraint rates across races are often a function of structural inequality, like people being not having housing, or people being brought in by police. So minimizing police presence is really important to us. Having a really diverse team, understanding the limits of AI, trauma-informed de-escalation. I remember just recently we had a young man come in of an Eritrean background, and he was a big kid and he was scared out of his mind, and he was trying to abscond. And then one of our team members, who was also Eritrean, said to me, "Oh, he reminds me, he could be my brother," and went out and talked to him and was able to share a language and a culture. And people I think we can overcome implicit bias by being more diverse ourselves. We're really interested in data-driven approaches to reduce wait times. I won't bore you with this, but we do a lot of modeling to figure out what staffing can look like to prevent. There's lots of different times you can wait. I'm sure you've all had this experience, and it's like extraordinarily annoying. Like you walk in and then you have to wait to register. Then you wait, you register, but then you have to wait to get triaged. And then once you get triaged, you have to wait for your first assessment, then your second assessment. Then you have to wait for the disposition. Then once you have a disposition, you have to wait for your bed to open up. So we're working really, really hard using research and data and partnership to reduce the wait times across those domains. So it's interesting, even though as we saw, like our volumes are, 500 times what they were when we started, our wait times are actually lower and time to place people to beds are lower. And then we also look to see are there specific groups that tend to wait longer. So, people requiring it can be so frustrating for patients and families. It's like, well, I got here 3 days ago and I'm still stuck in this emergency department. We have an EOU, which is a short stay holding unit. And I've seen other people go up to units, but there's certain kinds of folks that it's a little bit difficult. So if you need the psychiatric ICU, so if you were a person experiencing psychosis, that sort of means that you have mania or you're agitated or engaging in behavior that is potentially dangerous or disruptive to you or people around you. Not because it's your fault, because it's the illness. It does take a little bit longer to get a PICU bed because there are just so fewer of those beds in the hospital. Another example of specific population. So it can be really tricky to get a geriatric bed if you're over 70, over 65. Just because we only have 2 geriatric units, they have to be very careful to prevent outbreak. And so sometimes those folks tend to wait a little bit longer, but we're really invested to sort of finding these gaps and fixing them. Community partnerships, making sure that we can build out and build in, and people have direct lines to us, and building a culture of research and innovation. So one of the things that's really important to remember about mental health care and any kind of care. So if you have, I have 2 daughters, 11 and 7, and I remember when my 11-year-old was maybe 6, she woke up one day and she couldn't like move her legs. She'd had the flu, and sometimes this happens when you have the flu, like you get some like myositis in your legs, but it could be nothing, but it could be very, very serious. And I remember one of the reasons our family doctor and pediatricians say go to sick kids. Because like sick kids is sort of like built for kids like my daughter, like everything was kid size, just like the CAMH Emerge is built for people with mental illness. And when I looked out the window, you can see like the big research building, right? And research improves clinical care. It's always better to be enrolled in a clinical trial. It's always better to be in a research study because not only can it benefit your care, it also benefits the care of everybody who comes after you. One of the problems with emergency psychiatry is historically our patients have been excluded from research. They're too complex, they're too sick. We don't want to do research with people with suicidal thoughts. We don't want to do research with people with substance use. And so, like, how do you help people coming to emerges if you systematically exclude them from your research? So we have worked really, really hard. I'm running a study right now. It's a $2 million study, which follows people with suicidality, no matter how complicated they are, over a year with serial assessments to better understand like what helps them recover and what their illnesses are. We do qualitative interviewing, we do healthcare data utilization, we do blood and brain biomarker stuff. And we're really thrilled that now we have centralized research recruitment. So if you come to the CAMH Emerge, you may be asked to participate in a number of studies that we can recruit centrally for. And of course, you don't have to say yes. And if you're super stressed out, it might be the last thing you want. But I think respecting our patients and valuing them enough to consider it important to do research with them and for them. And with is really important. So all of our research teams have people with experience and family members as full and equal members of our study team. Improving, because how can you help people if you don't know what they want and what their priorities are? Improving flow through the hospital, we talked about that, and then ensuring opportunities again for complaints and feedback. As the medical head of the service, I would much rather have something come across my desk, Mark and I both, and be able to address it, not only to provide comfort to the family that is distressed, but also to improve our care overall. And I will say that I want to assure you that it can be so stressful. I understand that. In my experience, people are working in good faith. We just had a focus group with our Emerge team, and the thing that came up the most with our docs is I love working in a place where anyone can walk through the door and get care. I love working in a place where I can offer people service. I love working in a place where it's not just about the diagnosis, it's about the person. So I can assure you that is where we want to go. And in a broken system, it can be so, so frustrating, and we may not always meet these lofty goals. And if that's the case, I always want to hear about it. Thank you so much. So I will stop sharing. And then maybe if there are, I can't see the chat, but if there are any questions, we can talk about them or any comments.
Yes, thank you so much for that overview. We have a few questions that have come up so far in the chat, and I invite you, if you have others, please add them to the chat and we'll try to get through them. So one question is, so this question says, as an adult with sensory processing disorder, do you have quiet rooms in the ER?
Yes, I think this is a really wonderful question, and I think neurodiversity is so important to like honor and address and support. So we're working closely with the Israeli Center to figure out pathways to best support folks with sensory processing differences. And so we really work, if you can just flag it for us, we really work to get folks into quiet rooms. Sometimes it's so busy that it becomes impossible to do, but we do our best. We have 3 rooms in the front and we have 4 or 5 in the back, like in our assessment area where we can put folks. We also have things like weighted blankets. We have other like sensory tools. We can also like if it's flagged, I can like have someone else from the team come and sit with you and chat to you. There's ways to like turn down the lights. So I think sensory like being aware of people's sensory considerations is really important. So if you can just flag it for us when you come in and say like what are the things that can be really helpful, we'll do our best to manage them. Bearing in mind that sometimes our department is set up to work best if there's fewer than 18 people in it. And sometimes I come to work and there are 50 people there. And if that's the case, it can be really tricky. But there's also the opportunity to go sit outside. There's really beautiful areas outside of the CAMH Emerge, like where you can sit and like sit in the gazebo or take a walk, and trying to make sure that we can maintain those spaces is important. I think that's a
And
great question.
yeah, it is a great question. And if somebody were to, go outside and take a break, what is the mechanism to ensure that they, are when they can be seen, they can be
Yeah, so often we'll just give them a call, like you can leave your
yeah.
number. Or sometimes what we do, sometimes they can be a little bit tricky if it's super busy to keep track of folks. So
Mhm.
we thought about like doing like the thing you get at a restaurant where it buzzes. But there's like lots of reasons. So we're always like trying to find the best way to do it. One of the things that sometimes we do is we can say to a person, like just looking at the board at the people waiting to be seen, it's say if it's 3:30 p.m. I don't think you're gonna get seen till 5:15. Why don't you go come back at 5:15? And also
Right,
keeping in mind that there are some folks who it may not be safe for them to go, like if they're experiencing active alcohol withdrawal, which can be life-threatening. We do have to keep you, but then if you're being forced to stay, we try our best to see you as quickly as possible.
great. Thank you. Another question is, are cell phones allowed on adult inpatient wards or the ER? During COVID, a friend was allowed their phone, but the last time that they were in, it was taken away. So just wondering what the
Yeah,
overall policy is, I guess.
that's a great question, and I can't speak to the inpatient units because some of them have different policies. So I think a lot of them you can. There are some units like our child youth concurrent unit where they don't let you have a cell phone. That's part of their therapeutic contract. You're made aware of that. You have to sign a contract to say that that's okay with you. In general, we do allow folks to keep their phones because I think if someone took my phone away from me, I would be really stressed. Like if I couldn't
Mhm.
communicate with my family or I couldn't like, you know, distract myself. Like so we try to let folks keep their phones as much as possible. We also have like chargers available to help people charge their phones. We have I don't know if anyone's been to our site, but like the data is really spotty. So we do have like Wi-Fi people can connect to as well. The one thing around phones is that if there's a few reasons we would not want someone to have their phone. So again, there's specific units like the youth concurrent unit where they find that in the population that they serve, the phone can actually cause folks a lot of stress, and so that's part of their plan there. If you are, we just want to maintain everybody's privacy, especially the privacy of co-patients. So
Right.
we ask people not to film or take pictures. Um, and if people use the phone in an aggressive, like if you throw a phone, like that's going to be a no for us. If someone like your loved one calls and says this person is, calling me and making me feel unsafe or uncomfortable, that would be another reason. But these are very rare circumstances, and so for the most part, I think people have their phones with them in the department, as far as I know.
Great, thank you. Another question, which is a bit, it's general, but I think important and relevant, especially where we are situated. What might be the path for somebody who's homeless and experiencing a psychotic episode? Um, would they end up back on the street? Would they get shelter support? Um,
This is an excellent question, and it's something that we struggle with. And our
yeah.
bioethicist, Dan Buckman, and us have discussed this issue. Um, I want nothing more than to sort of consider housing as a human right and that we could support people and support their mental health until they can find housing. The difficulty with that is that when the social network is so the social safety net is so fractured in this province, like if we were to bring everybody into hospital for them to await housing, nobody would ever be able to get a bed anywhere or manage acute psychiatric emergencies. And so we can't hold people for housing. But if people are experiencing homelessness and also have an active psychiatric illness that requires treatment in the moment, of course we would treat. And we also have partnerships with things like CAMH and MDOT and like community like outreach services that can support people with mental health concerns, and we can get them like help support them get on wait lists for housing. Bridging does a lot of that, so we can refer to bridging and people can start the housing
Mhm.
application process for sure.
Great. And can you say a little bit more about the bridging clinic? Um,
So the bridging clinic is for people who come to the CAMH Emerge with acute mental health concerns, or they are admitted to an inpatient unit and are discharged. And it's a place where people can get brief, time limited drop in psychiatric care for up to 3 months to be bridged to another service or back to their family physician. I think the thing to remember about bridging is that if you do have like a psychiatrist elsewhere, then it doesn't make sense to use bridging as a service. And that it is like a drop-in model of care, which is great because it's the most accessible and equitable, but there can be waits there and you may not see the same person every week, but it's a really excellent service. But the other thing is CAMH also has great outpatient services. So if your family doctor is like, where can I refer a CAMH to get you seen? If you refer through the general program, the mood and anxiety clinic only has a few week wait right now. Like there are better options maybe than coming directly to the Emerge for bridging referral. There's also a virtual urgent care at CAMH, and all of these things are kind of detailed and available on the website for sure.
Great, great. Andrew, do you have a couple of questions that have
Yep,
come through to you?
I do. Thanks. This is really good. Thanks so much, Juveria. So, I don't know if you're gonna be able to answer this one. What time of day tends to have the shortest wait time in the ER, just in case you can schedule your emergency?
That's a great question. I think about this all the time. My whole life is like looking at charts and graphs and, trying to plan for contingencies and long tails and workflows. Um, it's a great question. I think that like some of the afternoon tends to be the worst time. Like if you come, at 3 p.m. So when I can tell you about my workflow, when I come into the emergency department, there's usually 30 people there. There are 3 docs. So that means I need to see 10 people in the morning and see and disposition them and provide them with care. So that means if you come, and then lots of people are coming through the day. So one of the things we did for this is we started a doc who starts at 11. So that 11 o'clock doc can then see new cases that kind of come through. Well, the morning docs are seeing all of their cases, which is awesome. And then we have another doc that starts at 1 o'clock and another doc that starts at 5 o'clock and another doc that starts at 9 p.m. So like we sort of do all of these pieces carefully. Um, like I think if you come in the afternoon, it tends to be like especially early evening. Like it can sometimes people often come like after work and they're kind of like, you know, you want to miss traffic and stuff. And so coming between, I would say like 3 and 7 is probably the worst time to come. We always joke like we love our patients, but it's like at around 3 o'clock the bus comes, right? Like everybody shows up, like 12 people will show up at once between 3 and 4. So I think like probably coming in the morning, like coming around 9:30 or 10 makes sense. Um, I think that that works pretty well. The earlier you can come, the more options you have, because if you have a bridging concern, you may be able to get diverted rather than waiting in the urge. Fridays tend to be a bit quieter than Monday, Tuesday, Wednesday, but it honestly, like we've done all kinds of modeling with like weather and like time of year, and on an individual day, it's very difficult to predict. All we kind of have our trends.
Thank you. One of the other questions, and things were going by kind of quickly. So there was a mention about our partnership with Mount Sinai.
Mhm.
That was a little bit confusing. Can you just talk a little bit about what that is about?
For sure. So CAMH and Mount Sinai have had a long partnership, and the question about it is like, so say if someone comes into the CAMH Emerge and they also have like a very severe leg infection and they need IV antibiotics or an assessment, we don't want them to not be able to get care at CAMH, but we also want them to get medical care as quickly as possible. We don't want to call 911 and have them go to any random hospital, which is really stressful. So if we have a medical concern at CAMH that can't be managed at CAMH, like we have medical doctors who work in the day. Usually stuff can wait overnight and the medical doctor will see you. But if we're really worried about something acute, we would call over to Mount Sinai and you would get seen at their emergency and then get sent back to our emergency. And the way the partnership works on the other side is historically, Mount Sinai has great psychiatric services. They have an inpatient unit and psychiatrists, but historically they haven't had psychiatry in their emergency department. So if you go to Mount Sinai and say you have a severe depressive episode, historically the emerge doc would see you and then you would get sent to CAMH for assessment. You may get sent back to Sinai if there's a bed there, but you would come to us. Now Sinai is expanding out their psychiatric service, so they do have an outpatient emergency psychiatric consultation service from 8:30 to 5, Monday to Friday. So if you come during those times, you'll see him at Sinai Doc. And if they have a bed available, if you need admission, they may admit you directly to their unit if they have a bed. If they don't have any beds, you would come to CAMH to wait for a bed somewhere in the system. So if you have a psychiatrist at Mount Sinai, I think it's great to chat to them and say, where should I go? If you have medical comorbidity, I would say go to Sinai for sure, just to get checked out medically before you come. If it's during the week, during the day, I would go to Sinai because there's a chance you'd be able to get directly admitted to their bed and then they can call down to their team down there. If it's after hours, like either Sinai or CAMH are fine, but generally I think it's great to get the care in the place where you are, because they just know you the best there. They have access to your charts, your files, and your doctor can advocate for you in that respect.
One of the other questions is, where can someone find out about and sign up for research studies?
That's a great question. So CAMH on the CAMH website has a research registry, and it'll take you through all of the studies that are actively being recruited for at CAMH. And it's a great resource.
Thank you.
And if you walk through the halls at CAMH, there's like often bulletin boards with like a bunch of studies posted everywhere.
Yeah.
Yeah, and we can share in our follow-up email, we can share that link to the research registry as well.
It's a bit of a slightly longer one. The question goes like this: non-psychiatric hospitals typically only have very short psychiatric appointments for inpatients. They have social workers for those experiencing housing issues, but the rest of the time there is virtually no other activities or any therapy. What does CAMH offer for inpatient outside of medication care, ECT, etc., for patients during their stay?
This is a really important question, and I think that historically psychiatric inpatient care is structured just as this person described. So brief visits with the psychiatrist, the focus isn't on sort of longer term psychotherapeutic approaches because that tends to happen when a person is more stable. The goal in our system is to kind of get people stabilized with medication, ECT treatment, social work support, and then a lot of the work happens after discharge. That being said, I do very much appreciate that. I always say to people, especially when I send them up on a Friday, that there's not a lot happening on the unit here on the weekend. And I think being really transparent is important. At CAMH, I think the model is quite similar for inpatient. There are things that are different across the units. I know that one unit right now is offering a mindfulness group, for example. There are medication groups. We have, therapeutic recreation and like our dogs who come visit, like small things like that. But I think a lot of it is kind of individually like care expected. Like I think we have this idea of like what inpatient psychiatric care, and I wish it kind of looked like that. It's sort of like what you see where, the psychiatrist comes and sit with you for an hour and you chat, and you kind of do activities all day. Unfortunately, in a publicly funded system, that's not really what you're gonna get, even at CAMH. But I think I agree with this person. It's really important to have programming when we can, whether it's psychotherapy group, different groups to help understand what's going on and support, and then to make sure that you're getting good medical care and psychiatric care as well.
Thank you. One of the folks is interested in knowing the ratio of men to women and the number of patients who are youth versus adults.
Yeah, I don't have it. I have one of the things that we have is a dashboard where we have all of this information and how it our trends over time. I don't have it readily available. I think we do see probably, I think we'd say 60-40 women to men, which is consistent with other hospitals. And we also have, of course, lots of non-binary folks who come too, which we want to provide support for as well. And then in terms of across the, one of the things that we're really proud of at CAMH is we do see people across the lifespan. So we see people from 16 to 88, 100, 108. And so there's the proportions of who is seeking care at what time. It tends to vary a little bit between months, between times of year, less young people in the summers, for example. But we do see quite a lot of young people. And I think that percentage of visits is definitely growing for us over the years.
Somebody is curious, they've heard about virtual visits to Emerge,
Mhm.
and they're wondering if you can comment on whether or not that's available.
So in the CAMH Emerge, we don't offer any virtual care just because I think in an emergency psychiatric visit, it's really important that we see you and we understand kind of what you're going through. And also it's a service utilization issue. If we offered virtual visits, it would mean that a lot of our care providers would end up being providing virtual care and then people are going to be waiting longer in the department. And so that's a concern. But the CAMH does have a virtual urgent care clinic. I think the information is available online. This is a clinic that is run by nurse practitioners. You do have to sort of be someone who's not in crisis to attend. Like they don't, it's not a great fit for people experiencing active suicidality, active substance use withdrawal. But if you want a psychiatric consultation, if you need a medication refill, if you kind of want to touch base to see what your diagnosis is, the virtual urgent care service is very useful. And I think it's kind of like, it reminds me of booking your vaccine. Like I think you have to log in the morning and like book in that same day, but it tends to be not too difficult to book, so that's always an option for folks. And just remembering that it's usually a one-time consultation rather than an ongoing clinical encounter.
Great, and we will we'll share information about that in our follow-up email as well. I have a question that's the question, oh, I've just lost it. But so you mentioned about families and how they are encouraged to provide information during the ER. And the question is, does that continue after the ED? So if they're admitted, how?
That's a great question. So, the ED, we do have the luxury of having it definitionally be an emergency. And when it's an emergency, there you have a little bit more flexibility in terms of privacy confidentiality legislation, because you're trying to make decisions. When someone is admitted, they're kind of in a safe place. If your loved one is made incapable to consent to treatment, then you would absolutely be involved at every stage of the process because their closest family member is often the substitute decision maker. If your loved one is open to having you be involved, then absolutely you would be involved and often do family meetings and other supports. If your loved one is very clear that they do not wish for their loved one to be involved or to receive information, that can be a bit of a challenging case. If they feel this way because they say, my loved one thinks I have schizophrenia. I absolutely don't have schizophrenia. There's nothing wrong with me. They're likely not capable to consent to treatment. And so your loved one would be involved. If the person is saying, I know I'm depressed, I know I have alcohol use disorder, at the same time, my family member stresses me out, I don't want to harm myself, I'm engaging in care, I do not want you to talk to that person. It becomes very difficult then to override that kind of the patient's own sort of moral code and what they want. But I think that if you have information related to safety, I think it can also it can be provided but if it's sort of like wanting to be involved in the care and the patient is capable to consent to your involvement, says no, and there's no acute safety concern, then it's a little bit different on an inpatient unit for sure. I know, and I should know is really, really challenging for families. Absolutely.
For sure. Thank you. And then there's another, one question is, do you need to be attached to CAMH to participate in research?
No, absolutely not.
So yeah, so that would be individual studies and their criteria. And then another question, what would you recommend people to bring with them when coming to the ER for the wait and for comfort?
Oh gosh, that is a great question. And I love that people are thinking about this because I know that like if I've had to go to a hospital, even to like have my kids and stuff, I always don't think about this carefully. So I'm glad that we're thinking about it. I think like everybody knows themselves well. I always love when I see people with books, because books are great because then, you know, when I always see someone reading something, I always ask them what they're reading and then we can talk about it, which is really nice. Sometimes people like to bring iPads. It's always great to have headphones with you if you want to watch anything, just because otherwise it can get a little bit overwhelming for folks with sensory kind of challenges and it can get loud. So, anything that you can watch with headphones, I think is really good. While we have lots of snacks, you may not like our snacks too much, which I totally get. So, I think like food and water, like a full water bottle. We always give, like, I always ask everybody if they want water and make sure that I give them water, but they're like the little kind of hospital cups, which is like not fun. So, bringing water, I think, is really important. I think like bringing a list of like your medications, a list of communication, remembering that we really try to balance safety and dignity. So there's some things that folks may not be allowed to keep. So if you have like really long, like, you know, like drawstrings and hoodies or like really long like headphones, like sometimes there may be things that you may not be allowed to keep. So just to be aware of that. And it's not personal and we'll keep it safe for you, but like we just need to make sure that not even for you, but for other patients, if they come across something, that it's a safe environment. So I'm trying to balance those things. Make sure you, like, if you have a charger pack or a charger, it's always good to bring because I feel like our Emerge, because the reception is so bad, drains charge quite a bit. So that's another nice thing to bring. If you're with a loved one, you may want to consider like making sure that you have like, you know, about parking, because you're like, you don't want to park right out in front and get a ticket. Take an Uber if you don't know how long you're going to be and your loved one needs to come back, things like that, just sort of like planning stuff.
I know you touched on this
Oh, the only thing
brief.
is like, please don't bring illicit substances to the Emerge. Like, we want to support you. Like, I know sometimes folks will be like really anxious from a substance use perspective that they're going to go into withdrawal, but please let us know if you have it with us. We won't get mad. Just give it to us. Like, it's always better when you can give it to us and then we can keep it rather than like finding out later or having people using the service, which is one of the the most triggering things for other patients as well. So we are very understanding and supportive and we will help you, but please to not bring any substances into the department, including alcohol.
You touched on this earlier, but I wonder if you can just help people differentiate between urgent care and emergency care. People don't want to, you know, the old saw that they don't want to come in if they don't need to, but
Of course, yeah, absolutely. And I think that I have two minds about this, and I think both are true. So one is that, you know, I think anytime you can avoid coming into an emergency department, it's great. Like if you can like negotiate, like I think your family doctor is a really good resource, like using your own community supports, you know, outpatient referrals is really good. But honestly, if you feel awful and you need help, please come see us. Like, I think we often undercall our own distress. And if you are like missing work because of panic attacks, if you are crying all day in bed, if you are not yourself, please come see us. Like, I can't guarantee that I'm going to admit you to hospital. I can't guarantee that I'm going to fix it in the moment, but at least we can get started together. I think the things that are like less urgent for me is like when sometimes folks come in and they're like, you know, I've been on 6 or 7 medications for 10 years and I don't think they're the right medications. I want someone to have a look at them and make recommendations. Like, that's not a great situation because like we're only going to meet you once. Like, it might be better for your doctor to put in a referral to our mood service to get you seen. Sometimes people come in and say, you know, I think I have like X psychiatric diagnosis, often ADHD or autism, which are very, very prevalent and really important and really like, you know, prominent in our communities. But we don't do a ton of diagnostic work in the Emerge because to do diagnostic work, you need to do a careful, thorough, longer assessment. So we don't tend to do a new diagnosis. But my goodness, if you are suffering and the suffering is new and getting worse, please come. Like, please come see us. That's what we're here for. And I think that most people like really, really, really like are careful about using services. I think most like I really think we have this idea of society that people abuse emergency care. That's not my experience at all. Like, I think that like 99% of the people who come see us need to see us, and I'm so glad that they saw us. And the people who like are like, oh, my family doctor, I can't get an appointment till Thursday, but I'm going on vacation and it's Monday. Can I get a refill? Like, that's not like an ideal situation because there's usually ways to problem solve that. But if you can't problem solve something and you feel awful, like please, 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 please come. I'd rather see you than not see you.
great.
That's
Thank
great.
you.
Thank you. I I know we're at time, so there's just one question that's kind of clarifying from a previous comment, and then we can wrap up. So regarding substances in the ER, are we able to bring our own PRN meds such as Ativan or migraine meds for
So
use while waiting?
that's a great question. So usually what we do is you can bring them. One of the cool things about our model is the pharmacist often sees you before I do. Like they see you really, really quickly. And so what I would say is like bring your PRNs and then maybe give them to the nurse. And then the pharmacist is going to see you pretty quickly and you can say, here are my meds. And then I will order those medications for you in the department. So you'll get the same Ativan. It just would be like we would just know what it was. Anytime in a hospital, you always prefer to give someone like what it is. If it's like a weird and wacky and like kind of hard medication to get, like sometimes folks who are on like really complex HIV medication regimens, for example, it can be difficult for us to get them. Bring it in, and sometimes what I'll do is I'll write an order that says patient may take own medication, and then we would provide it. But always just good to be like upfront, transparent. Give it to the nurse, and if you need your own supply, we can help you with that. It's just like not ideal for us to not know what you're taking in the department because imagine if you feel, which is totally reasonable, right? You feel super anxious, you take an Ativan, then you get drowsy, and then we're like, why is this person drowsy? Like, what's happened? So just transparent is good, and we're there to help you, and we really believe that people should have access to their PRNs when they need them.
Thank you so much.